Hello, everyone. It gives me great pleasure to talk to you about a novel concept in the treatment of type 2 diabetes. Now, we know that type 2 diabetes constitutes about 95% of all the patients that we treat. And the old paradigm that we have been following for all these years has not really worked very well. What do? We start with diet, try it for 3 months, it won't work. Then we add metformin, that will work for a few months. Then when that fails, we think of adding sulfonylurea, or like this, it goes on. What happens is the patient's sugar never gets under control. So nowadays, the concept of early and aggressive treatment, whereby we reduce the clinical inertia and get the sugars under good control, has really emerged. And the verified trial actually showed that. If you compare a DPP4, if you combine a DPP4 inhibitor and metformin, instead of using metformin alone, you get much better results. And of course, we have shown this with sulfonylurea and bigunate combination even 30, 40 years ago. I have published both animal as well as human experiments to prove this. So what is new? What is new is that instead of, first of all, more aggressive treatment, if you find somebody whose A1Cs are really bad, don't just go in the conventional route and start with one drug and then add another drug and so on. That doesn't work. Secondly, today we have drugs which go far beyond the glucose lowering potential. For example, the SGLT2 drugs in general and empagliflozin in particular has been shown to actually prevent heart attacks, to prevent heart failure, and to be good for the kidney as well. It also helps to reduce weight, to reduce blood pressure, to reduce the sugars, and in many ways it is beneficial. Let us take the example of a patient. Let's call the patient any name you want to call her Geeta. So Geeta is now 50 years old and has obesity. Her sugars are not very well controlled. Her HbA1c is 9%, and she is on metformin alone. Okay, and is also a little borderline. She's beginning to show little microalbuminuria. Her father and mother both had heart disease. That means there's a strong family history of heart disease. Now, in such a situation, instead of just following the routine now, after metformin, we'll add one more drug, then we'll wait and see. There is a certain sense of urgency in treating this particular lady. Because if you don't treat her early, what will happen is that she can develop either a heart attack or a stroke, or she can go into kidney problems and so on. So we must urgently bring her sugars down, try to reduce her weight, to reduce her blood pressure, and also provide something which is a protection against her heart and kidney. All these you can get in one drug, and that is empagliflozin. So the EMPA-REG trial showed that this drug actually prevents heart attacks, and of course it prevents heart failure. It also reduces the 3-point MACE, and it prevents cardiac death. So what more do you want when you have a drug like this? Now, even if you use empagliflozin alone, I mentioned that the A1C was 9%. You may bring the A1C down to 8%, but you may not be able to normalize it. So in this particular situation, if you use a fixed drug combination of a DPP4 inhibitor like say linagliptin, and if you use an SGLT2 drug like empagliflozin, and this particular combination is available in our country. Now, the other advantage is that when you use this fixed drug combination, the cost is actually lower by about 20-30% than using both the drugs separately. So coming back to this lady, suppose with this particular pattern that I just described, we give her this particular drug in addition to metformin. What will happen is each of these drugs will bring down the A1C by at least 1%. So A1C is going to come to 7%. I told her blood pressure is a little borderline. That will come down due to the EMPA. I told you she has little microalbuminuria. Both linagliptin and empagliflozin are supposed to be friendly towards the kidney. So therefore, it will also help the kidney. And the loss of weight, the reduction in the weight, will also bring down the blood pressure and also help the kidney and help in reducing the cardiovascular risk. I mentioned that her father and mother had heart disease, and therefore she is very likely to get heart disease in the near future because of genetic factors. So my plea to you would be, think of early combination therapy, hit hard and hit early. In the first few years, we're able to keep the sugars under good control and all the other parameters. I call it as the ABCD approach. The A1C is A. you have to keep that under control. B is blood pressure. Keep the blood pressure really down. When you have microalbuminuria, even try to bring it to 130/80 if possible. LDL cholesterol, not only below 100, try to bring it below 70 in Indians if possible. And the D stands for diet, discipline, exercise, no smoking, stress reduction, and all that. If you follow all this, we can ensure that this lady has 20, 30, 40, 50 years of productive life without any complications of diabetes. I have shown in my research and in my publications that people with diabetes can live up to 50, 60 years without any complications. And long-term survival is possible. I published all this in the last few years. So my very best wishes to all of you, and I do hope that you will start a new paradigm in the treatment of diabetes by hitting hard, hitting early, and ensuring that the first 10 years, if you keep the sugars under very good control, you develop a very good legacy effect, and thereby you can prevent all the microvascular as well as the macrovascular complications of diabetes. I would like to thank Lupin for asking me to participate in this podcast, and I wish you all the very best. Thank you.